Welcome to another session of Fresh Natural Live. It's Monday evening, and we have a great show for you tonight. We're going to talk about an issue that I think we sort of beat around the bush from time to time on our show. And there was a recent article published in the British Medical Journal. A number of my, health advisor colleagues on YouTube have done discussions on this. And it's really an op-ed, if you will. And the title is The Illusion of Evidence-Based Medicine. So we're going to talk about the issues of how industry affects the science of medicine and affects what we do, what we recommend in medicine. And I think it's something really important for you as either a healthcare consumer or a healthcare provider. If you're a healthcare provider, you're probably well aware of this topic and you probably have stories of your own. However, if you're a healthcare consumer and you don't know the insights to how medicine works and how we make the recommendations we make, you really, really want to look at this show because and also pass this information on to others, because what I'm going to do is go through this op-ed. They hit some nice highlights, but myself and my colleagues want to share some of our personal experiences because we have a lot of insight into this particular topic. So again, the illusion of evidence-based medicine. So just stay tuned. Welcome back. Welcome back. So we're going to give you a little bit of inside story of how things work in medicine. And I'm going to be talking about an opinion piece published in the British Medical Journal. And so I'm going to invite my friends and colleagues on first and foremost. I'm sure they have a lot to say about this. They've worked in this field for a considerable length of time. Welcome, Dr. Pam Atkins and Dr. Ford.
Hello.
So, the illusion of evidence-based medicine. This article, these two brave men were brave enough to publish this in the British Medical Journal. I guess the journal editors were brave enough to publish it. Hello, Deborah Payne. And so I guess we need to be brave enough to talk about it, huh? So, but I think it's a topic that's very poignant, and so what I like to do for the sake of the audience, I'm just going to go through. I'm going to read much of the article. I just highlighted lots of it, and part of it is a fairly short article. I think they did a good job of being very succinct and making a statement. So part of me wanted to just read it all, but I said no, that wouldn't be good for the show. So I highlighted maybe about 40% of it, and so I'll read through that part. And then I think we just get into a discussion, because I think each of us has a lot to say about this topic because we all have our own experience. I think each of us can write a similar op-ed just based on our perspective, our individual perspective in medicine. So let's just jump right into this article. So it's written by, co-authored by John Giardini and Lamont McHenry. The subtitle is simply this: evidence-based medicine has been corrupted by corporate interests, failed regulations, and commercialisms of academia. And that's what these two authors argue. So the advent of evidence-based medicine was intended to provide a solid scientific foundation for medicine. It depends on reliable data from clinical trials, most of which are conducted by pharmaceutical industry and reported in the names of senior academics. Now, the release into public domain of previously confidential pharmaceutical industry documents have given the medical community valuable insights into the degree to which industry-sponsored clinical trials are misrepresented. Now, there are two references here. I'm not going to even speak to these references. However, I will say to the audience, I will be giving a more in-depth discussion on this topic, and I'll talk about these two references on our private channel. And if you want to learn more about that, go to montgomeryheart.com/journey. And that's our private channel that talks about your health journey. But there is a heart data alluding to that. Medicine is largely dominated by a small number of very large pharmaceutical companies that compete for market share, but more effectively, they remain united in their efforts to expand that market, which is really important. Expand the market for the need for drugs, devices, or the like. Scientific progress is thwarted by the ownership of data and knowledge because industry suppresses negative trials. That's important to know. Fails to report adverse events, and does not share raw data with the academic research community. Now, let me break that down. So let's say, for instance, I say, well, I have this drug X, which is supposed to, let's say, treat high blood pressure. And so I give drug X to a group of patients with high blood pressure. I give placebo, a sugar pill, if you will, to a group of people with high blood pressure. And let's say after I study this, not only do more people with drug X have higher blood pressure, but more people on drug X die. Well, that study may not get published. That's the first part of the statement. The other part of the statement is that, well, we may not give all the raw data. We may manipulate the data so that the study come out positive instead of negative, or it comes out positive instead of inconclusive. So that's essentially what the authors are saying here. Patients die because of adverse impact of commercial interests on the research agenda, universities, and regulators. Now, that's a very, very strong statement. Patients die for these reasons. We'll get into some comments and things that I'm familiar with, and I'm sure my colleagues have some familiarity with certain examples. University departments become instruments of industry. Now, I'm going to pause right there because, in my years of training, I remember, and I'm not going to talk about the institution I trained at. You can look it up in my CV online or whatever. But one of the institutions I trained at, one of many, I remember in the infectious disease department, some of the antibiotic companies or the pharmaceutical industry that wrote for antibiotics were sponsoring the salary of some of the fellows. And so that's somebody's trying to guess where Vita Brown's says UT. That's one of the institutions, but there's several. But we're sponsoring the salaries of some of the trainees. And so, that's one example of how they become instruments. So through company control of the research agenda and ghostwriting of medical journal articles. So ghostwriting, in other words, you publish something and then they'll get somebody to write the article for you. So the actual authors whose names are on the articles did not write the articles, but they actually have some pharmaceutical companies hire someone to write and publish it. And then the authors are like senior people in the institution. So they say you're a senior person at, prestigious institution XYZ. You may have your name on a journal as lead author or senior author, which is usually your last name, but you didn't write it. And so this may be controlled by industry. Academics become agents for the promotion of commercial products. So in other words, you put your name on the publications because it's almost a quid pro quo. The pharmaceutical companies, they pay money to the universities. They sponsor their research. So like if you have a big lab and the university, well, I'll write you $1 million to do a study on this, whether it's a cancer drug or heart failure drug, they may support your lab. So, that's some of the things that they would do. Now, the corporate university also comprises of the concept of academic leadership. So now they go at the leadership level. So deans who are very high up in academic centers, They reach their leadership position by virtue of distinguished contributions to their disciplines, have in places been replaced with fundraisers and academic managers. So the traditional deans who reach their place by contributions through true academic work, they're really replaced by people who are quote unquote deans, but these people are more surrogates or sponsors for the corporations. They're referred to as key opinion leaders or KOLs. Now, physicians are selected based on their influence on prescribing habits of other physicians. So if you are chief of a department, or if you are head of the, let's say, the pharmacological committee of a hospital, you have influence as to what drugs go in that hospital. I remember there was a drug I used to like to give my patients with heart failure. It was Natricor. And it was a great drug. It had a lot of negative press, and I don't know, they didn't pay off enough people, but I thought it was a great drug. Pretty effective in heart failure patients, but it was taken off the formulary. That's the word I was trying to come up with. If you're head of a formulary of a hospital, then you could become a key opinion leader of a corporate entity. But unfortunately, the company that came out with Natricor didn't have enough KOLs in their favor, and this drug was pulled off the formulary. I was sad to hear that. In fact, I was probably the only one in the entire Memorial Hermann system using that drug. When they pulled it out, the chief of the chief of the cardiology service, section head, and the chairman of medicine, chief of cardiology, came and sat me down and said, "Hey, your drug won't be available anymore." So I guess someone told me to come and talk to this guy. He's on the line for it. But anyway, KOLs represent results of industry trials at medical conferences and in continuing medical education. Now, that's important. I'm going to touch on that a little later. Instead of acting as independent, disinterested scientists and critically evaluating a drug's performance, they become what marketing executives refer to as product champions. We're going to hit on that hard in the discussion session. Vita Brown has a lot to say. Let's see. What about lavish trips to conferences? Well, we're going to talk about that, Vita. So ironically, industry-sponsored KOLs appear to enjoy many of the advantages of academic freedom, supported by their universities and industry. So while universities fail to correct misrepresentations of the science from such collaborations, critics of the industry face rejections from journals, legal threats, and a potential destruction of their career. So on the one hand, you have the guys who are representing the corporations, who have these conflicts of interest, who are misrepresenting the science in favor of the collaboration with corporate industries. But on the other hand, you have people that are, I guess, being honest, facing legal threats and potential destruction of their careers because they're not, following the course of the corporate interests. So vested interests will always override rationality of evidence. So regulators receiving funding from industry and use industry funded and perform trials to approve drugs without the most cases seeing the raw data. So in most cases, they don't see the raw data. They just, the regulators, this will be the FDA, and what they're saying here, and of course, this is a British medical journal, so it's outside the US, but regulators like the FDA, they receive a large part of their budget comes from industry that's publishing articles. So in essence, you are policing your boss. You're policing the person who's writing the check for your salary. So drug companies are permitted to mark their own homework, in essence, rather than having their products tested. I'm going to talk about this whole topic in relation to some recent things that I'm not going to mention on this show, but we will talk about it on the private sector in much more detail. Go to montgomeryhart.com/journey and join the Optimal Health group. I think you'll love it there. You'll get a lot of good information. Our proposals for reforms include, so none of the authors state what the problem is, but they propose a solution. Now, I don't know if this is going to fall on deaf ears, but here it is. They propose a liberation of regulators from drug company funding. Okay, taxation imposed on pharmaceutical companies to allow public funding of independent trials. So instead of, the regulators receiving direct pay from the pharmaceutical companies based on the trials, they would just cut that form of funding off and just tax all these guys in the pharmaceutical industry, a hefty tax that then goes to a treasury that then funds independent trials. And perhaps most importantly, anonymize individual patient level trial data posted along with study protocols on suitable, accessible websites so that third-party payers self-nominated or commissioned by a health technology agency could rigorously evaluate the methodology and trial results. In other words, just make your data public, make your data available to other experts, outside experts, who can look at it and opine on it and critique it. And so, that's really the critical factor. But I like the whole part about separating the funding or removing the direct connection of the funding with regulators, because I think that's really important in terms of not having our regulators depend on the guys that they're policing for the funding. So I'm going to stop right there. That's the end of the article. But for those of you who didn't get the title of the article, the title of the article is The Illusion of Evidence-Based Medicine by John Giardini. I think it's worthwhile getting a copy of it. And what I'll do is I will copy it and put in a copy of it in the chat, and I'll also put it on link. So, Dr. Atkins and Dr. Atkins, what say you?
Ladies first.
So you don't think this is true, Dr. Ford Atkins? You think that these guys are all on the up and up, and you've never seen anybody come in your office back when you're a podiatrist trying to promote any kind of device, or surgical device, or huh?
Many stories to tell. When you said experience, yes. Well, let me tell you a quick story first, so I can get my
Sure.
story. Initially, when I finished my training in podiatric medicine, and we were doing a residency training in the hospital, I think the first month into our program, a pharmaceutical company came in. They were touting this great IV antibiotic that they wanted us to perform a clinical trial, and they were going to donate X amount of dollars to our residency program. We all thought we was going to get an increase in salaries, which didn't happen, but we got books and other things. But and we were supposed to do a 6-month trial comparing that IV antibiotic to 2 others. It was a comparative study. It's what it's meant to be. So we were excited. When you get out of school, you want to, within the first few years, get a publication. So I was all excited. I was going to get published and everything. And we did the trial, lasted 6 months. We compared the IV antibiotic to 2 others, crunched through the data, stayed up late at night, got everything done, and presented the results and presented the paper. But we never thought about the fact that in the paper it showed that the drug that they had presented to us wasn't as effective as the other 2 drugs in the comparative study. It was equal to or less than as far as its efficacy. So, but we published the data because that was the true and accurate data. And they got our information. We were excited. We turned our papers in, and we just waited, a month to the publication come out, and it never came out. So when we talked to our chief of staff at the hospital, I said, well, when is that publication coming? They said, well, they decided it wasn't going to publish it because the information didn't fit their. I don't exactly remember what they said, but it didn't fit their criteria, what they were looking for. The results didn't fit the answer they were looking for. And so I was really disappointed, and I couldn't figure out. That was my first reality of that when you publish as a researcher or you publish data, that if it doesn't meet the expectation of the person who's funding you, then it's highly likely you're not going to get published. Or they buried that. So that was my first experience. But I do want to really emphasize that there is definitely an illusion of evidence-based medicine, because It's the funding that comes in any research are coming from. It's like the fox is watching the hen house. So you can't really if you tell the truth, if the truth is true, then it's fine. But if the truth falls anywhere short of what the expectation is, then you don't get published.
Yeah, that's exactly right.
I have some more to say later with Dr. Pam.
What's been your experience?
Your mute is on.
Oops, it's still muted. It might be your.
Your mute's on.
Oh, let's see.
Is it off now?
Yep.
Can you hear me?
Yeah.
Yes or no?
Great.
Yes, we hear you.
Okay. All right. So you can hear me good?
Yes.
Okay. For some reason, I'm not hearing you as well. So let me put this earpiece back in. Okay. Can you still hear me?
Hello?
Yes.
Okay. So it's just a sad state because if research is done and it doesn't see the light of day because the pharmaceutical company or the sponsor doesn't like the results. So we don't, as you stated in the article, or if you have adverse effects that are suppressed, it's a sad thing. So later on, patients may suffer from these adverse effects or from not getting this information from the research to the light of day. I remember once attending a breast cancer support group benefit, and there were different people speaking. There was one gentleman that was from, I believe, an African country, but he had done research, I believe, in Texas. I believe it was Scott and White, but his research was of a herbal product, plant-based product, but that it had had great success against cancer cells, and it was destroying it and had what looked to be a curative effect. And so when it was presented for the pharmaceutical company, he presented it to turned it down and said, we're not going to fund something that is curative because we can't make money. We want something that you have to continue to have treatment for. So that was eye-opening for me, at that point, because it shows if you can take something and be cured, or the symptoms or the disease is alleviated, pharmaceutical companies may not be interested in that because they're not making money on a regular basis for you doing treatment and rounds of treatment like chemo.
Yeah, that's right. I mean, these cancer institutions are not interested in making cancer history. They're interested in making cancer prevalent. And the cancer patient, I remember one patient was telling me that, her oncologist told her that she has cancer, she's going to have to live with it, and getting chemotherapy is going to be just like dialysis. You're just going for a round, you suppress it, it comes back, going for another round of chemo of some sort. And so it's just an ongoing cycle. And that's where they see it. They see it not in an attempt to cure cancer or absolutely eradicate it in some form or fashion, but really just to kind of manage it as any other chronic illness. That's really the goal of these pharmaceutical industry, really the goal of the device and pharmaceutical industries. It's really to have a product that just keeps on providing, what I call palliative care. So I was telling a patient the other day. Actually, it wasn't a patient. I was talking to our group that I'm leading a detox with our employees, and so we meet on Sundays and talk about experiences. And so I was sharing with them that allopathic medicine is not care or therapy that's ideal for curing or really effectively treating an illness. What we're doing is palliating. We're palliating symptoms and palliating signs. So it will reduce the pain, or reduce the cough, or reduce the shortness of breath, or reduce the blood pressure, reduce the cholesterol, reduce the whatever abnormal lab, but it's not getting to the core of the problem. So really what we're doing in the Western medicine is practicing palliative medicine, palliative care. It's just that, we think of, hospice of palliative care for the person who's within, a few months of dying, et cetera. In fact, that's not known, because I've known lots of people in the hospice. They live years and get discharged from hospice. Not a whole lot, but a fair number. But the long story short is, most people relying on Western medicine is getting palliation medicine, not really therapeutic or curative medicine. And so that is a critical thing. So
Well,
please
one thing I
tell
want to
that
answer,
word. Go ahead. Yes, sir.
I want to answer that. You're absolutely right. It's palliative care, but I think in the late '80s they took it to a whole different level when they came out with the whole system of managed care, and we thought that sounded good because we thought everybody was going to get health care. But the idea of managed care is, again, it's like palliative care on steroids. That means we're going to keep the disease, you keep your ailment, you keep your problem, but we're going to manage it. That means we're going to use prescription drugs, we're going to medicine, surgery, whatever. We're going to manage it. We don't want you to ever get rid of it, but we want to manage it. And so people think that managed care is a good option. Where, but in traditional medicine, you want to alleviate the problem. You want to get to the underlying cause. If you solve that, then the problem is gone. But that's not even the goal in healthcare these days. It's to manage your sickness. And so when you hear that, even you mentioned cancer. Making cancer history sounds very good, to a person to listening to it. But when you think about it, what does that mean? Does that mean that cancer is going to go away? They don't say that. Does that mean that we talk about the history of cancer? We don't say that. Or some companies that will say, we're the best in cancer care. So that means they never say they cured anything. They just say when it comes to caring for you, when it comes to managing your cancer care, we're the best in managing your care, because we have, more drugs, we have more options, whether it's, like you say, devices with proton therapy or all the different therapies they have. Everybody has a technique now, but nobody will say we're going to alleviate the problem and you're cured. And again, understanding what cure means in cancer. We talk about they consider you cured if you've survived 5 years after your last treatment. So if you have a 5-year survival rate after your last treatment, they consider it a cure. But that's not what it means, because there's so many people that in year 6, 7, 8, 9, 10, they have a turn for the worse, so they don't make it. So if I think a cure, I want it to be a lifetime situation. I want it to be, if I'm cured, then I don't have to deal with that issue. I can move on to other issues other than keep going back every 4 or 5 years or having reoccurrences of that cancer or other multiple cancers caused by the therapies I had that caused cancer.
Yeah, I think the history part is that we want to make more money than anybody in history treating cancer. so that's probably the history part. But the conflict is real. And so in 2017, I think it was, or 2018, I'm almost certain it was 2017, we presented some data to the American Heart Association, and it was the use of plant-based medicine. So we showed how to define plant-based diet, reduce metabolic conditions, including lipoprotein(a) and other inflammatory markers, C-reactive protein and the like. And so we were presenting a poster there. So it was in Anaheim, California. My son at the time was in college. He was in Los Angeles at Occidental College. And so I went out there and spent some time with him, and I gave him a guest pass to come to the AHA meeting one day. And so we went there, and so I walked him around the exhibit booth, the exhibit hall, rather. And the exhibit hall is a huge section of the convention center. And I kid you not, there are pharmaceutical companies and device companies, and many of their booths cost upwards of $1 million. they've got walls and, lots of their equipment there. And there's lots of, some are serving food. They have, you've got like an area that's like a living room. You can sit and lounge around. And it's just an amazing amount of money that's spent. And of course, they have their, corporate guys and their salespeople there talking about their products. And this is one of the two major meetings for cardiology. And of course, the main publications, typically the major studies that are being presented at the meetings are sponsored by drug companies. And so they'll have, a key opinion leader who's presenting the data. So to be, key release. I remember we participated in some of this nonsense over the years. We were one of the centers, the number one center to be a investigator on the heart failure drug Entresto. Many of you may have seen the commercials of the drug Entresto. Well, it was a 5-year study, maybe 10 years ago when we were doing the data, I forget, but we were one of the sites who were studying that. In fact, we enrolled the first 6 patients in the entire world on that study in our center right here in Houston. And we enrolled more than that. But what happened was once they've gotten positive data, and of course they changed the protocol many times throughout the study, but once they, received the positive data if they needed, they immediately, of course, they had an ethics board, quote unquote, independent, quote unquote, ethics board, who then, called the study. Once they called it, they shut down all the centers, and it was very rapid. They shut down all the centers. They collected all the data. They crunched the numbers. The data was then published in the New England Journal. I'm thinking within weeks of them closing all the sites. And so it was then published in the New England Journal. Then at the very next ACC meeting, it was one of the main topics released in terms of a Pfizer drug, new drug and heart failure. And I kid you not, if you look at the outcomes of the drug, it only showed a very small advantage in terms of reduction of hospitalizations and overall well-being. It didn't really halt heart failure, it didn't reverse heart failure. All it did is allow the progression of heart failure, as did the usual drugs, with just fewer hospitalizations over time. There was also a survival benefit over, I think it was a 3 to 4 year survival benefit over the previous drug, which is an ACE inhibitor that they looked at. But that's really what they had. But this is a blockbuster finding, and it was major news in the cardiology area, and was released, and now it's part of the indications, which is another important thing. I don't think they mention it or emphasize it enough in this article, but the control that that the device and pharmaceutical industry have on our research, it then has a control on our standards of care. Now, let me break that down for the audience. So what I mean by standard of care, published in our major journals. I'm going to use cardiology as an example because I'm a cardiologist. But the American College of Cardiology, American Heart Association, they come together and say, okay, here's the standard of care for treating high blood pressure. Here's the standard of care for treating heart failure. Here's the standard of care for treating hyperlipidemia, heart attack, stroke, etc. So when you have that standard of care, level 1, these are the treatments we recommend. Level 2, this is treatment. Level 3, it's not indicated. So you want to have at least a level 1 or 2B indication for a certain condition. So if they say, okay, what's the standard treatment for congestive heart failure? Well, you got an ACE inhibitor, a beta blocker. You can use a certain calcium channel blocker. Now you can use, Entresto, which is a certain drug for heart failure. You can use digoxin, you can use et cetera, et cetera. So these become the standards of care. So a physician who's practicing, they'll look at the standard of care, plus, in their training, they're looking at the standard of care. when we take our boards, the board exam, in order to become certified, is the standard of care dictates what the right answers are. So in essence, the big industry who's writing a check to academic medicine, who's writing a check to all of our industries, they are dictating what the indications are for treating routine diseases, and they're dictating what the indication are. So physicians are almost compelled. So it's one aspect that we're indoctrinated in our trainings, and so we don't think outside the box. But not only are we indoctrinated, but we're also compelled to use these things because these are the indications. And so if you have a patient that has a problem and you find yourself in litigation, they may bring an expert against you and say, well, Mr. Expert, Dr. Montgomery do the right thing with this patient. So Mr. Expert's, well, the indications for heart failure is not raw fruits and vegetables. It's drug X, Y, and Z. And so so when I'm treating patients and using a natural approach, I have to be mindful of that. And so we are very careful. We manage our patient when we wean them off medication. We follow them very carefully, et cetera. If they don't comply with what we're recommending, they get the standard of care. So it's really important for us to understand the extent of power and control that the industry have over your care. It's not the licensed physician who's managing your care. I have to be as honest as I can. It's really the industry that's dictating what that licensed physician says. And if that licensed physician works for a large entity, and now most physicians are employed by a university or employed by a large private corporate entity, which is also compromised by industry, many of them, those physicians have to also comply with what their boss says. The university says, well, you must use these drugs, or whatever the case may be. So there's an enormous amount of control that industry has over the practice of medicine. And I think as consumers of medicine, you have to be aware of that. And you have to do your research, and you have to be cognizant of what's going on. I'm not saying don't take your doctor's advice or don't take a medication that they're prescribing. I prescribe medication on a regular basis. But you have to be cognizant of the nature of the field. You have to be cognizant of the influencers on there, and you have to take control of your own health. On this podium, we've had lots of shows talking about how to optimize your health and control your blood pressure, sleep, exercise, nutrition. The first step to avoid, being trapped in this medical, trap is to grab the steering wheel and steer your health in the right direction. And so that from an individual standpoint, because as individuals, there's little we can do to fight this behemoth as individuals. But collectively as individuals, what we can do is we can take control of our own health, do the right things, optimize our nutrition, optimize our exercise, fresh air and sunshine, and not have to rely on this. And then if you take away the consumers of the legalized dope, then you can probably have an impact to a certain extent. But I'm going to pause right there and get some feedback from my colleagues. Can a plant-based diet promote? Y'all seen an interesting question. Can a plant-based diet promote blood-based cancers like leukemia? Can it promote blood-based cancers? I'm not familiar with a plant-based diet promoting cancer. I know patients with cancer actually are able to fight on plant-based diets, actually able to fight cancers better.
I didn't know if the correct word she was choosing was promote, but if she's saying promote, but we think we have seen plant-based diet, it is basically we're taking away a lot of toxins and chemicals. And I think a lot of chronic disease like cancer is a response to chronic being exposed to chronic chemicals, pesticides, radiation, electromagnetic waves, other things, toxic water. So the more we clean up what we put in our body and expose our body to, many chronic disease, including cancer, can improve, because we have to look, those are the underlying factors, and it's usually multifactorial. So a lot of times we're taught we kind of promote in medicine that it's sort of the luck of the draw when you get cancer or when you get a chronic disease. But there's many things in our diet, our lifestyle, and exposures that can affect that. Even in children, young children that get cancer and some chronic disease, especially cancer, there's some exposure even in utero that may have exposed that child to it, to be a patient, a leukemia or cancer patient, or adult cancer patient. But we know with leukemia, there's a lot with chemicals and toxins and radiation. So the cleaner our diet, we can eat plant-based, but if it's not a clean plant-based diet, where we have a lot of pesticides and chemicals, that may not be the best diet. But generally, a plant-based diet that is organic and chemical-free or less chemicals, especially the dirty dozen and things like foods of that nature, produce of that nature, the better you're going to do. And it can be a good step in the right direction. So diet is always very important. However, many times we get patients that are cancer patients, are going through chemo and radiation, and the oncologist has told the patient, my oncologist has said I can eat whatever I want, because there's no power or emphasis on the diet, but the emphasis on the chemo and the radiation, or not on any herbal things that may assist with the immune system. So we have to be careful about that, and ask questions and be advocates for ourselves.
Yeah, it's interesting you mentioned that, because I hear a doctor, also Ms. Kincaid mentioned Dr. Joel Kahn. We know Dr. Kahn, and he's an advocate of healthy living and plant-based nutrition. And the same thing happens on the advanced heart failure clinic. And I've had patients go to the different institutions, and they have bad heart failure, and when they get on the transplant unit, say, well, you can eat whatever you want, and it just doesn't make sense, because even if you and I'm presenting the real truth about health tomorrow, and I'm talking about the use of nutrition in the acutely ill patient. And I've had patients who present with heart attacks or end-stage heart failure, and many of these patients are too sick to undergo surgery. And so when I put them on a raw detox, even in the hospital, I'm able to turn them around. I'm going to present a case series of that and talk about the mechanism. And actually, we're launching some research that's going to look at the mechanism of how powerful nutrition is, plant nutrition is, in turning off inflammatory conditions, even people who are acutely ill. And I've had people in the ICU when I give raw plant nutrition through PEG tubes and the like, they start to turn around, and not in a matter of years, obviously, but a matter of hours to days. And so, but this is something that needs to be understood, at least by the general public, because if you have a loved one there in the ICU and you feel powerless, at the very least, you can say, look, allow me to bring the food, to my loved one, and not have them eat the hospital food, and have them eat super green smoothies and other super nutrients, green algae. And so I'll be presenting this data to the Real Truth About Health. I need to find that link, and I'll share it with you when I find it. But again, this is information that we should all be aware of. and we should take control of our lives at whatever stage of health or sickness that we may be in.
Well, one thing I want to really continue on what you were saying. Um, well, the topic of our subject is the illusion of evidence-based medicine, and I think that word evidence-based medicine has really been beat up and whipped. It started off as a good thing, and now it's like a catch term for whatever you want it to be. And like the article we're referring to, it says the illusion because people have used it for different purposes. But the idea of evidence-based medicine, it means that you make decisions, you make medical decisions and choices based on the information you have, the data you collect, whether it's laboratory tests, blood tests, whether it's diagnostic testing, clinical evaluation, a critical clinical evaluation of the patient to know exactly what's going on. And then once you have that evidence, then you have to use your clinical skills to sift through the evidence, to make analysis, to come up with a conclusion. I know from my experience in traditional medicine, it doesn't really happen that way. I call traditional Western medicine textbook medicine because you learn in school what the textbook says, and that throughout your career, your knowledge is based on textbooks and what you learned originally. Now you can go to conferences and pick up a little bit here and there, but you're really getting fed what the person who's giving you information wants you to know. But to really be on top of it, evidence-based, that means you have to look at the data, look at the journals, look at trials, be constantly on top of that, which is a difficult thing to do. And then finally, the whole idea of evidence-based medicine means you get the patient involved, where the patient can make a decision. What are their lifestyle preferences? What are their desires? What do they want to accomplish? In getting managed or treated by you as a physician. And so, but I think the evidence-based medicine we see right now, and that means again it has to be evidence-based. You have to have a guideline. A lot of times with the pharmaceutical companies that are the topics we've been talking about, they will have an idea, or they have some data, and then they come up with a hypothesis to fit the data. And then once you have a data, you say, well, if we could spin it this way, then we could sell the product, or we could sell it that way. Sometimes with evidence-based medicine, they have data, and then they'll or they have a hypothesis, and then they will keep tweaking data and continue to tweak the trials until they get the proper information they want to promote it. I guess what you were referring to a few minutes ago, Baxter, when you said they will leave out some information, they will add in information, they will change the trial, they keep tweaking it just until they get it right. So, so when we hear about whether it's any new breakthroughs in medicine, when they say it's evidence-based, well, I as a physician or as a medical professional, I want to look at it and say, well, does this mean that it's evidence-based because of the evidence you presented by a company is saying it's okay, or is this truly a fact? Is this truly information you see? So when we talk about whole food nutrition as compared to doing pharmaceuticals, I call it true evidence-based, because if you change the diet, if a person says a dietary change makes a big difference, well, what got you in the position you were in initially was your diet. It was what you were eating, what you were putting into your body. That's how you ended up sitting in front of the cardiologist or in front of your internal medicine specialist. So it's only a little bit more than common sense that you need to make a change there. And when you make that change, you see the difference, you see the change going based. That's true evidence-based. You don't need anybody, nobody to come tell you this is why it happened, because you see right before you. I mean, you publishing on that. We see it time after time again. So evidence-based and getting with a person to do that. The only other
Oops, you went mute. You just went mute.
Excuse me. The other problem with evidence-based medicine is that practitioners today are not really trained to deal with that. The new catch term for a lot of healthcare professions is functional medicine. Now we have people talking about functional medicine, physicians and functional medicine, and that's a good idea and it sounds great, but functional medicine means you address issues based on the function on how things function. So I'm evaluating your heart function, evaluate your kidney function, your liver function, your digestive function. But that's what medicine should always be. We always look at the function of organs and the function of systems and the function of your body as a whole to make sure that's what's working. So if people understand that there's really more holistic or more, I guess, a more natural approach to healthcare is to be functional about it. Is to address function and not just address a symptom. We said, well, I know your kidneys got problems, but rather than kidneys, we'll just give you some medication and you get into trouble. But we never get the underlying problem of why is the kidney not functioning properly, or why are the liver is not functioning properly, or what's the underlying causes of the heart malfunctions you have. So, and like I said, medicine will address those things, but they never alleviate the problem. So we want to understand what true evidence-based medicine is. Knowing a practitioner that will start from the top, gathering evidence. I know in your practice, Baxter and Dr. Pam, gathering data, testing is the first thing that needs to be done before you can make a decision. And in traditional medicine, you go to the doctor when you have symptoms, and they will write your prescription before you get out of the front door. And they haven't they take the blood when you're there, but they don't have any results back. So what are we treating? We're just like shooting in the dark, just based on conclusions, or again, what the textbook said. I'm through.
Yeah, I think that's a great point, and it's really cookbook medicine. You say textbook medicine; it's the textbooks are cookbooks.
Yeah.
Which I don't know. I think that might even be a compliment, because I think a lot of doctors are so influenced by the device, the drug reps. I mean, so it might be drug rep medicine.
Yeah.
Because that the data is influenced by the drug reps. So these are the things that we're really dealing with. And I think as consumers of medicine, or if you have loved ones who are consumers of medicine, many of you, if you're taking the time to look at this channel, you're probably very forward thinking. You're probably taking control of your own life. We're probably you know a lot of other people out there whom you can share this video with. And by the way, give us a thumbs up, and like and share this with anybody who you think would benefit from this information. And if you haven't done so already, please subscribe to this channel, and also take a look at our other private channel, montgomeryheart.com/journey. I'll give you that information as well. Learn about our private community. The Doctors Atkins, myself, and everybody on this channel, along with other faculty members, speak on this private channel. We are able to say things, speak more liberally. So come and join the private channel if you feel inclined to do so. I'll give you some information on that as well, both in the chat and on the speaker in the banner in a few minutes. But back to the point about the control of industry, and as we come to the final minute, we have to be mindful of this. And I think we as the general public, I mentioned earlier, as one individual, you may not have the power to overcome this. But I think I need to revise that statement, because we all have we have individual power, and we also have collective power. And I think it's worth realizing that it's really something that we have to take control in our minds. That first and foremost, I'm the steward of this body, and I'm the person that's responsible for its care. It's not some doctor or pharmacy or hospital, whatever. When I'll talk to my patient, I say, look, it's a partnership, okay? And I'm going to make recommendations. I'm going to make very strong recommendations. But at the end of the day, I want to get your input to it, because oftentimes, I should say, the patients are frequently right in terms of what they need to do and why they need to do it. Once they have the right information, patients make the right decisions. And I think when we make the right value propositions in our lives, we tend to make the right decisions. Now, it may not be the decision I think that's the best decision at the time, but over time it ends up working out for the patient's betterment. And so I give credence to the patient, and but I try to influence as much as I can toward what my recommendations are. But I think it's a partnership, and I think you should, as consumers of health, should have that attitude as well, that you're in control and it's your responsibility to take care of your health, and it's your responsibility to go to the end of the earth, if you will, to do the right thing to improve your overall well-being. Any final words from Dr. Pam Atkins or Dr. Ford Atkins?
Yes, I just saw that Charles Hall asked did plant-based diet help glaucoma, and if you Google that, you may find some anecdotal or some patients saying that. But yes, we see the eating more plant-based diet and increasing the raw can lower glaucoma pressure in the eyes, and many times the doctors that have already put you on medication say, oh, the medicine's working better, but really the diet has improved it. We don't recommend people stop taking the medication, but if you incorporate this diet, you may have the doctor work with you and see in the future, can you decrease the medication as you continue the plant-based diet and increase raw with a lot of antioxidants. But just like blood pressure can respond from that type of diet, the glaucoma pressure in the eyes as well. We've seen that.
Yeah, I agree. I agree with that wholeheartedly. We see that all the time. When patients comply, they go back and their numbers are better. We just see it all the time. So thanks for catching that question. I think I may have glanced at it and overlooked it. That's a great question. And thanks for catching it. But again, there are therapeutics, natural therapeutics for just about every condition that I can think of. And we treat very, very sick patients. I mean, very, very, very sick patients. I alluded to in the hospital. I got somebody in the hospital right now that's very, very sick. I've got them on raw smoothies. I got them on super green foods and things like that. But we see them turn around if they do the right thing. And if they don't follow it, now when you feel very, very sick, you have to be 100%. I'm not going to get into the details of that. But the point I want to make, and I think Drs. Atkins, Floyd, and Pamela Atkins can agree, and they see sick patients also, if you do the right thing and make the right changes, you can, turn your health around. And so it's really never too late unless you're 6 feet under. Now, we've gone to the cemetery a few times and sprinkled some raw juice, so we haven't had anybody get up yet, but, we're still working on those studies. But people above the ground, I've not seen anybody not turn around who've been fully compliant. Dr. Ford Atkins, you get the final word.
Thank you so much. I would just have to say, you were saying that when you evaluate people and you make strong recommendations, I think that's the most powerful thing. And when you give people all of the detail and the information they need to make a decision, most people are intelligent enough to make the right decisions. They do better when you say 70, 80% of them will make the right decisions, because if they're presented with the proper information, they can do that and they can make the right decision. They can improve. But for the patient advocating for himself, you have to go back to the common sense. You are what you eat. If you're not doing well on what you're doing, you have to change something. Albert Einstein said it many times. People hear it all the time, but you have to apply it to every situation, every circumstance in your life. Get with the right person who can help you, and then and get all the information, and then you can make the right decision, or decide that I trust in the person to the recommendation they give me are correct. So again, I think evidence-based medicine is good when you have good evidence.
Absolutely. Couldn't put it better. Well, thank you, colleagues. I'll see you backstage as I close out. Everyone, as usual, this is a topic that needs further discussion, and we will give it further discussion on our platform. To learn more about that, go to montgomeryheart.com/journey. But I want to thank each and every one of you for joining us tonight. If you haven't, hit the thumbs up button, share, like, and subscribe. Please share this with anyone who you think will benefit from this topic, which is a very, very important topic. So until next time, keep it fresh, natural, and live.